Welcome everyone to today's endocrinology grand rounds. We are very pleased to have Dr. Harold Bays, who is on our faculty as clinical associate professor in the Division of Endocrinology and Metabolism. He is also the medical director and president of Louisville Metabolic and Atherosclerosis Research Center. Dr. Bays obtained his undergraduate degree in medical school and residency and fellowship, all from the University of Louisville. He has been here in Louisville, established the Louisville Metabolic and Atherosclerosis Research Center. So he took a very interesting path after his fellowship and has been extremely successful in this field. He has conducted over 600 clinical trials in diabetes, obesity, atherosclerosis, lipids, and has been very active in publications and designing studies. He has been very active also in several of the national and international societies, including the Obesity Society, the ACE, ADA, also the National Lipid Association, Obesity Medicine Association. So he has been very active in these and has numerous publications, over 350 publications in this field. So he'll be talking to us today on some of the things that are upcoming and some of the things that have recently been developed in the field of obesity, which is really exciting because I think for the last 50 years that I have been studying these things, everything was there was nothing there to do. We just studied it, but now we have something that we can do, so.
Very good. Well, thank you very much. Okay. As he mentioned, my name's Harold Bays. Principal investigator. I'm up to 700 clinical trials. Just kind of crossed that not too long ago, and if things keep going, I'll be up over 1,000 by the end of next year because it's just such a busy space right now, particularly in the obesity research area. So what I'm going to talk about is obesity medications and development, what's in the pipeline. Many of these you will know because you're all doing research on them as well. These are disclosures, so I work with a lot of companies. And yes, because they're investigational, I'll be talking about investigational drugs. That's a disclosure, okay? As far as the objectives, again, mainly just going to focus on what's in the pipeline, what new, and also maybe new concepts. What are some of the newer concepts that we have in obesity treatment? So first off, what are GLP-1 receptor agonists? I think you all know this. GLP-1 receptor agonists, what happens is once people eat food, then the gut produces these hormones. And the way that it's supposed to work is when you're eating food, there comes a point where when you've eaten sufficient amount of food that these incretins decrease your hunger. And then as the food passes on through, then there may be other hormones and such that are altered such that it increases hunger. So that's how it's all supposed to work. All right. Well, the problem is that you have all this physiology that's supposed to trigger when you're supposed to eat, when you're not supposed to eat. But when you match that up against trillions of dollars of research into how we can just extract, all the sugar and extract the fat and all those things, you can completely overwhelm the body's natural balance. And again, I'm not being critical of anybody. I mean, my sense of it is at some point there were some cave people walking around. As one person said, okay, if I sell this meat over here, I can get, maybe some clothes or something, some fur or whatever. And he says, yeah, I'll trade you. And then this other person goes, well, that's a pretty good deal. What if I just add some salt to it? Okay, so he gets meat, but he adds salt to his, and everybody goes, I want to go there. And then the other person says they're going to add sugar, and then the other person, so it's free enterprise. I'm not saying that people did this deliberately in order to harm people, but I think it's all clear that now it's come to such a science that the processed foods are so researched that again, I think it just overwhelms and overcomes our body's natural physiological state and such, then we get the obesity. The other thing is the hormones and your nervous system reaction to having high body weight really is not near as effective as if you have low body weight, right? Now, you might want to say, well, that's just political correctness. It is not political correctness. How many times have we seen patients that have blood sugars, 200, 300, 400, hardly have any symptoms? You get a person that has a blood sugar of 60, 50, 40, major difference. So what's the essential point? The essential point is the body defends. The body defends against starvation. And we just don't really have very good intrinsic ways in which the body combats having the overweight. So what we do is we employ these systems that our body already has. We make them into pharmaceuticals. And here you have the GLP-1 receptor agonists. They decrease hunger, increase satiety, increase insulin secretion from the beta cells, and delay gastric emptying. Also improve adipocyte function, oddly enough. What about GIP, glucose-dependent insulin-tropic polypeptide? Well, what's interesting here is this particular hormone, in addition to possibly reducing hunger, what it might do is decrease the nausea. So if you were able to combine a GLP-1 receptor agonist with a GIP, what you might be able to do is use higher doses of the GLP-1 receptor agonist because you have less nausea. And then it has a bunch of other potential effects that I've listed here. And again, improving the adipocyte function, what I've termed the adiposopathy, the sick fat and such, improving that. And so you have improvement in metabolic functions and such. And then what about glucagon? I'm not as clear on the benefits of glucagon as maybe other people are, but they are being used in therapeutic agents, and it is a very important component, so you're going to have to know about it. Where you're seeing, so I've listed all the, a lot of these effects. I'm not going to go over them, but what I would say is one of the real emphasis on the use of glucagon is the sense, based upon preclinical, the sense that it's going to improve fatty liver. So I think that's where you're going to see a real niche for these GLP-1 receptor agonists and glucagon agents would be in the patients who have the fatty liver. All right, so another concept. So those are those concepts. Another concept is there's a difference, a fundamental difference between having a fixed dose combination therapy. So like if you were to have an ACE inhibitor and hydrochlorothiazide, you put them together, it's fixed dose combination pill. We do that all the time, right? Ezetimibe plus a statin, we put them together, right? So that's how we're accustomed. That's how I've been accustomed for over 35 years in doing combination therapy. But that's not where the obesity space is, mainly. Where the obesity space is mainly are these unimolecular agents that have multiple effects. So it's not as though you're taking this and adding it to this and putting them into a pill. It's that you're manipulating these molecules such as they have different effects. And I've been in advisory meetings where I said, that just sounds really hard. And they're like, oh, come on, it's got to be hard. But apparently it's not as hard as I think it is. All right? And that's the reason you have so many agents out there that have these dual mechanisms, even though it's unimolecular. And some of these oxyntomodulin-based therapies, oxyntomodulin is produced by the gut, is that it also has this dual mechanism of action in that it has GLP-1 receptor activity as well as glucagon receptor activity. So again, I think that's another reason why people are developing these things. I think we all kind of gravitate around how do we come up with molecules that are naturally found in the body, and then maybe just use higher doses of them, like insulin, right, or GLP-1, or in this case, oxyntomodulin-based therapies. All right, so what are some examples of GLP-1 receptor agonists? I think we all know these, the liraglutide, semaglutide. And as you can see here, a whole host of these are in development that are GLP-1 receptor agonists, including oral formulations. What about GLP-1 and GIP receptor agonists? Well, we all know about tirzepatide, which is a GLP-1 receptor, unimolecular GLP-1 receptor agonist, and also GIP receptor agonist. But there's also other ones, these dual agents, these unimolecular dual agents, and we're doing so much work with these right now. They're fairly far along in development. And then there's even a GIP receptor antagonist, which, if you think about it, does that make any sense at all to anybody? Right? That's one of the big controversies that are out there now, or at least if not controversy, just curiosities, is that it appears preclinically as though if you take GIP and you have an agonist, you have weight reduction. If you look at preclinical and you have a GIP antagonist, you also get weight reduction. And you might say, well, that makes no sense whatsoever. Okay, how can you have both antagonist and antagonist, and both of them? And the one that's furthest along in development here is the Meritide. And it's a fully human monoclonal antibody to the GIP, and it has a GLP-1 receptor agonist. Now, there's some theory that if you have chronic GIP agonism, that causes desensitization and ultimately a loss of GIP receptor activity. And I don't know if that's true, but that's what you'll hear. What I would encourage you to do is like expand your brains, expand your minds about other possibilities. So we have agonists that activate receptors. You have antagonists that impairs active receptors. But then you have these things called inverse agonists, where it binds to the same receptor as an agonist, but it has antagonistic effects. And this functionality, it can be all over the place. So gone are the days where you could just assume that if it's an agonist that did this, an antagonist that does that. It doesn't work that way. There's a wide variance of how it is that the molecules that are being developed can interact with receptors and come up with very different effects. So here's one of my theories. Wonder if it just happens to be that you got two roads that diverge, but at the end of the day, they meet in the same place. Is it possible that with agonism, you have these anti-obesity effects, and antagonism, it has different anti-obesity. They work through different mechanisms. And it just so happens, coincidentally, that you end up with weight reduction. Is that possible? Well, I mean, that's what the data would support. And so we're just going to have to wait and see. All right, so what are the GLP-1 glucagon receptor agonists for obesity? And this is what I was talking about, the excinomodulin. It's a natural substance. I think we gravitate towards saying, how do we get a natural substance and then employ that in the treatment of our patients? And so it is being evaluated not just as weight reduction, but also as a evaluation for the treatment of MASH, the metabolic dysfunction associated steatohepatitis. Delayed gastric emptying, increased satiety. And each of these have variable effects upon whether it be the GIP or the glucagon. Now, again, name of this lecture, name of this presentation, new concepts. I would encourage you to be very cautious when you hear people tell about how it is that it increases energy expenditure. And I think I've been ranting about this now for 5 to 10 years. I think people are coming my way. Okay, I do. Because I don't hear them say it as much. At least they're not saying it around me. Maybe that's what it is. But there is no evidence, to my knowledge, that these agents increase energy expenditure in humans. Okay, I just don't know the data that supports that. But you hear people say it all the time. And I'm like, increased energy expenditure, I said rodents, but not humans. Okay, so how can we come to some sort of détente? How can we come to a mutual understanding? And so this is what I encourage the people that are developing these agents to do. I'd say, how about this? Instead of telling people it increases energy expenditure, which I just don't think the evidence supports. Like if you were to put somebody on, calorimetry or something, I don't see that the energy expenditure goes up. I just don't, no evidence of that. But wonder if you were to say, look, one of the main issues when people get put on these agents is their resting metabolic rate goes down as they have weight reduction. So instead of saying that it increases energy expenditure, wonder if you were to say what we're trying to do is we're trying to mitigate the decrease in energy expenditure. So in other words, if you add, a glucagon agent to a GLP-1, maybe that you have less reduction in energy expenditure. That I can buy. I can go down that road. Okay, but what I can't do is say that that increases energy expenditure. Well, you have agents that increase energy expenditure, right? The uncoupling proteins. You're familiar with, bears that hibernate and in the mitochondria, the uncoupling proteins, and it generates heat instead of storing energy and such. You can go on the internet and purchase these agents that work through uncoupling proteins. What are the downsides? The downsides are hyperthermia and death. Okay, so other than that pesky death situation, I think a lot of people say, well, I like get a little warmer, or I'd like with that, it's not worth it. Okay, it's not worth it. So that's where if you start mucking around with people's uncoupling proteins for mitochondria, you can, instead of storing energy in the form of fat or whatever, you can burn it off at heat. And initially it sounds great until, like I said, you realize there's some adverse consequences to doing that. All right, the problem, as you might have already surmised, with the GLP-1 glucagon combination is, what do we use glucagon to do? Well, we use glucagon emergency kits. So we use it to increase blood sugar. Well, is that what you want to do to our patients with the overweight and the obesity? Are we wanting to increase their blood sugars? I don't think we are. So what's the key? The key is you got to get that balance. You got to get that balance where you're getting potential benefits of the glucagon while at the same time avoiding the hyperglycemia and other things. And that's the trick. That's the tricky part. So if it turns out that the glucagon effect is so powerful, you're getting hyperglycemia, that drug's not going to make it. On the other hand, if you have really robust weight reduction with the GLP-1 receptor agonist, and overall you're getting pretty good weight reduction, you're getting some of the potential benefits of the glucagon, like I said, maybe reduction in fatty liver and such, but you're avoiding hyperglycemia, well, that's the sweet spot. And so that's where the agents that are out there now, that's where they're headed. Okay, so here are some examples that you can see here. They end in dutide. Okay, dutide. What about GLP-1 receptor agonist and amylin analogs? Well, I'm certain you've heard of CagriSema, right? CagriSema, which is cagrilinotide and semaglutide together. And then there's amycretin, and then this hot off the press. Okay, hot off the press. As you can see here, I'm one of the authors on this paper here. This is for eloralintide, which is an amylin analog, just amylin. Okay, it's a selective amylin receptor agonist. And you might say, well, how does that kind of match up with GLP-1 receptor agonists? The answer is, remarkably, it's pretty good. Okay, it does pretty well from an efficacy standpoint. And whoever thought, I wouldn't have thought, whoever thought an amylin analog or an amylin receptor agonist would have that degree of efficacy and such. So eloralintide is and I presented this I did the safety portion. This was at Obesity Week. Oh no, it's the American Diabetes Association. Or was the Obesity Week? I can't remember. It was one of the two. Anyway, it was a big deal. It was like had its own session and such. I did the safety presentation. Here, what we presented is that this is a selective amylin receptor agonist that specifically activates the amylin receptor. Okay, and your amylin receptors are formed by the calcitonin receptor combined with this what they call RAMPs. Okay, receptor activity modifying proteins. You trust me, you will be hearing about this. So if you haven't heard about it before, you've heard it now, ramps and amylin receptors. So the idea is, again, find that balance, that perfect balance where you're trying to get as much of the amylin receptor being activated and the least amount of calcitonin involvement. All right, so it's being developed for Alora is being evaluated for obesity as well as the type 2 diabetes mellitus. This is the trial that it was a phase 2 trial. And what you can see here is that depending upon the dose and depending upon the escalation strategy, because as you know, in general, you start a low dose, escalate, 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 escalate. Depending on which of those that you do, you can get anywhere from, let's see here, 9% to 20% weight reduction. Well, that's getting close to some of the GLP-1 receptor agonists, right? So that's what I'm trying to say is it was a surprise to me how efficacious this turned out to be. But it's a phase 2 trial, so we need to see phase 3. Because again, a little bit surprising to me. The other thing that was remarkable is, depending upon the dose escalation strategy, very well tolerated. Very well tolerated. And that's what you're going to hear a lot when you talk to people about the amylin. What they're going to tell you is, oh yeah, I heard that they're like really well tolerated. I think a lot of people, that's what they hear. A lot of times maybe forgetting the efficacy, but it's that tolerability that I think that, again, potentially this phase 2 data, need more data. Need more studies. But I think this is, Alora achieved clinically meaningful weight reductions, generally well tolerated, supporting its potential as a promising obesity therapy. What about retatrutide, which is GLP-1, GIP, and glucagon agonists? Got all three. Do we need all three? Well, what I can tell you is the data, and we certainly see this within our clinical trials, would support the retatrutide is quite efficacious. Okay, you're talking about like 25% weight reduction. I mean, we just had a recruitment meeting today at the research site, and my coordinators were telling me, even with just GLP-1 receptor agonists alone, their experience is probably like your experience. We've had patients that have lost 100, 150 pounds. Now, I don't think it's all due to the drug. I do think there are those patients out there when given access to the kind of facilities that we have and such, dietitian, caring staff, people motivational motivational interviewing, these types of things, that they really can change their lives around. Now, does it happen often? No, maybe 5 to 10% do you get that kind of extreme weight reduction. But my feeling of it is, there's some people say, well, there you go. 95% of people are not going to respond. Yeah, but what about the 5 to 10% that did? I mean, are we going to just throw them away? I don't think so. I think we should celebrate it when we have our patients that, again, really become engaged in self-care and such and get these dramatic results, because it isn't all just about the drug, in my judgment. So again, here you can see here that the type of weight reduction you get is 25%. We call it triple G, right? GLP-1, GIP, glucagon triagonist. You heard triagonist as well. A triagonist or triple G. What about muscle acting agents? This is, again, a little area of controversy and such. As you know, whenever there's weight reduction, anywhere from a third to half of the weight reduction can be from lean body mass. And the biggest change of lean body mass is going to be attributable to skeletal muscle, right? So we don't want that. We would prefer our patients have reductions in the body fat and not have reductions in the muscle mass or lean body mass. That's what we would prefer. And you can see here in the step 1 trial with semaglutide, about 40% of the weight reduction was due to changes in lean body mass. And of course, that's variable. It can be anywhere from 25 to 50%. So what should be the expectation? So we do lots of DEXAs. we do lots of DEXAs on private patients. When I mean by private patients, I mean people just call us up and just want the DEXA. They're not even really patient. It's not like we go through insurance. They just pay for it cash. And many of them are engaged like physique competitions or bodybuilders, or they're just interested in their health, right? The expectation is that about 30% of when they have weight reduction, 30% is going to be a reduction in lean body mass. So that's the expectation. We have had, I think, maybe 5 patients, been doing this for a long time, maybe 5 patients who actually were able to increase their lean body mass while having reductions of 20, 30 pounds of, fat and such. But we've had some, but the degree of effort and work and everything that has to be done in order to achieve that is extraordinary. As I said, I maybe had 5 patients that have done that. Really hard. So that should not be the expectation. Patients shouldn't be told, well, if you just did some resistance training and some dynamic training, you can really not, avoid getting that loss of lean body mass. Don't tell people that, because that's not fair. Now, again, you can mitigate it. You can make it so it's less, and you should absolutely encourage people to engage in physical activity, absolutely. But I don't think we should set it as an expectation. The other thing is, this is the real value of getting body composition. Because we've had, again, if this person's gaining muscle mass and losing fat, when you like if you were just to measure their BMI, it didn't look like they did anything, right? Because there's only going to be marginal changes. Well, that's not fair. Here they had dramatic reductions in body fat, increase in muscle mass, when you're judging them based upon their BMI, which shows hardly any change. But then if you were to look at it from body composition standpoint, what they've done is astronomical. And I think we should, again, celebrate people's successes and not just look for ways to just crush people. They're doing a good job. All right. What about, yes? Well, of course, we're right in the middle of doing the clinical trials. So I can't answer you definitively, but what I can say is that one of the concerns that people have when prescribing any of these newer, highly effective anti-obesity drug treatments, one of the concerns is that you're going to develop sarcopenia, reduction of muscle mass. And by extension, if you already have somebody that, say, for example, has osteopenia, if you add osteopenia, okay, on top of somebody who now has a reduction in skeletal muscle, and now you've diminished their overall physical activity, well, that's just a disaster waiting to happen. So now you end up with osteosarcopenia, right? So that is a major concern. I think that's something that's really being focused upon. And in virtually all the studies we do, there's always going to be a DEXA sub-study. So we're looking at that very closely. All right, so how are we going to assess? So we have these agents out there whose purpose is to maintain muscle mass. Sounds great. But then the question becomes, well, how do you know if you're doing anybody any good? How do you know? Well, you can say, well, that's so easy. Just do muscle biopsies. I've been in advisory meetings where I go, what about doing muscle biopsies? I'll ask. And the people who I trust know what they're talking about. They're going, that doesn't help at all. How's it going to help? Like, there's nothing about a muscle biopsy that's going to help you determine whether or not you're maintaining muscle function. Okay. Well, how are we going to assess it? Well, I can tell you how we assess it. First off, we do get the DEXA scan, okay? But that's not functionality, is it? That's body composition. But we still do that. So we're still looking at lean body mass, percent body fat. We look at the amount of visceral adiposity and such. So this is our DEXA. This is my DEXA that we have. And then, yes, sometimes we still do the bioelectrical impedance for some of the studies. But we also do step devices. So I was going to show off mine. I left mine at the office here before I came here. I got nervous. But we do the amount of steps per day. So that's a measure of muscle functionality, if you can do more steps per day. We also do motion devices. People with weight reduction often have enhanced mobility. Stair devices. I mean, when you hear it, it sounds really complicated, but then when you see how it's actually done, like a lot of things, it's not quite as impressive. But what you do is you step on the mat down here, and then you wear this device, and then you walk up steps, right? And at times, the speed by which you go up the steps. So it's a step device. 6-minute walking this is probably the number one thing that we do. So you find a place where you have a straight hallway here. So we have that. So you go up and you can't see it, but there's a cone at the end. So go back and you come back and you do that. And you see how far that you can walk for 6 minutes. So that's a 6-minute walking distance. And then here's a 30-second chair test, where you're going sitting to standing. And what's really interesting here is the chair. I mean, who knew? I remember when I first started doing this, they said, "Oh, we're going to send you a chair." I got chairs. And then, no, we got to have like research grade chair. I'm like, oh my gosh, what is well, if you think about it, look what it has. It has a wide base. It's got no arms. It's got a sturdy back, sturdy legs and everything, which is exactly what you need when you're going to do 30-second chair test in patients with overweight and the obesity, right? You do need to have. We found, we did need to have this. And then the picture's maybe not so good, but dynamometer, you hand grip test and such, all right? So you're like, well, there you go. You have measured all these different ways of muscle. So now we clearly are going to know that if a person has weight reduction and we put them on one of these agents that are going to spare muscle, we're going to easily be able to tell if there's improvement in muscle functionality. Not so fast. Because all of these therapies that we use that result in weight reduction, the GLP-1 receptor agonist or the GLP-1 GIP or whatever, when you have weight reduction, what do you think happens with the functionality of all these? Even as you lose 30% in lean body mass, they all get better. They all get better. So here's a perfect one. We published this in, I'm second author in this paper. This is once a week semaglutide in patients with osteoarthritis. People all got better. And what was really interesting, I presented this at Obesity Week as a poster. The improvement in the 6-minute walk test did not correlate to pain scales. Did not correlate to pain scales, but it did correlate to weight reduction. The 6-minute walk distance correlated to weight reduction, did not correlate to pain scales. Now, why is that important? Because what you're going to hear from people, they're going to say, well, the thing with the GLP-1 receptor agonist, they got all these inflammatory effects. How do you know that the effects you're seeing are not anti-inflammatory? Well, at least with regard to osteoarthritis, doesn't appear to be anti-inflammatory. Appears to be mainly due to the weight reduction. So I think people need to be really cautious by trying to attribute things, other than the weight reduction. I'm not sure we've gotten that completely sorted out. Your other people going to disagree. You're going to hear other people that are going to tell you it's already been proven. The effects of GLP-1 receptor agonists marginally due to the weight reduction, mainly due to the direct effects of the GLP-1 receptor agonist. I don't agree with that. I don't think that's supported by the sciences yet. All right, so what are some of these muscle-acting agents? Well, they worked on the actin or the myostatin. Maybe there's some anabolic agents we've looked at and such. So there's a whole bunch of them that we're evaluating right now. But again, the issue is, how are we going to know? How are we going to know if there's benefit of muscle function? The only way that you could know is if you measured people who had the same degree of weight reduction, and one was on the muscle-sparing drug and the other one was not, and see if there's a difference in functionality. That's the only way I know how to do it. But this is going to be really hard. And then the other thing is, if you are maintaining muscle mass, then what is going to be the criteria for approval of the drug? When it goes in front of the FDA, what's going to be the criteria for approval? You can use BMI? Well, how fair is that? Because if you're maintaining muscle mass, then the BMI is going to be increased. And now you're going to be just acting like, because the BMI didn't change as much, that somehow that's less effective on weight reduction when the opposite is true, right? So I think there's going to be a whole lot to sort out, both from scientific standpoint, functionality standpoint, and regulatory standpoint. It's just really challenging to know exactly, where these agents are and where they're going. I guess the first thing is we got to prove that they work, and then we got to better sort these things out. And as I'm sure you have experienced, it's, just back in the days, back when I started out being a lipid guy and did all the there were some tough times. There were some tough times with some of the lipid agents, and it's the same here. Some of these newer agents, everybody wants to get on the obesity bandwagon and such, but it can be tough. And what are the side effects that are really causing these drugs not to be able to go forward in the future? The same effects as it's always been. Early in development, a lot of times it's prolongation of the QTC. So we don't ever see them anymore, right? They're pretty good about weeding those out. But liver enzymes still happens. Still happens all the time. Not all the time, but it still happens, reasonably frequently. Of the reasons drugs end up not being developed, it would be because lack of efficacy, and then certainly increase in liver enzymes. And it doesn't take too many. You're familiar with Hy's law, right? Increase in ALT, increase in AST, and increase in bilirubin, right? Hy's law. If you achieve Hy's law, you're done. Your drug doesn't go further. And that gets to be really tough. I did a presentation at the American Heart Association decades ago on a drug called lepaclostat. It was a squalene synthase inhibitor, kind of in that pathway of cholesterol synthesis. In the phase 2 and 3 development program, we had like 2.5 cases of Hy's law. Drug is done. Doesn't take too many. Okay. And I got to tell you, from the investigator standpoint, whenever we have, patients that do have the increase in liver enzymes, many times they can really go high, and it's hard on the patient, but it's also hard on the staff and everybody else, because we're doing novel agents. We don't know what's going to happen. Then there are other types of hunger, appetite suppressants and such. And then other, sort of miscellaneous things. Okay. So what is the relative efficacy of these GLP-1 receptor agonists? Well, I think we know this. We know that semaglutide has robust weight reduction. We know retatrutide is robust weight reduction, and we know tirzepatide has robust weight reduction. Liraglutide, not so much. Some of these other ones, though, are doing quite well. What about the tolerability challenges? And here again, I'm just throwing out new concepts. Here. I'm not convinced that the same, whether it be neurological or hormonal pathways, whatever, that affect hunger and satiety and such, is the exact same as vomiting. Because we've seen people. I'll give you an example. Decades ago, we were one of the sites that were involved in PYY. PYY is also a hormone produced by the gut. PYY acting agents. And these people in this trial, throwing up all the time, vomiting all the time and everything. What happened to their body weight? Nothing. No effect upon the body weight. And you say, well, that doesn't make any sense at all. They're throwing up all the time. How is it they're not having any change in body weight? Well, because guess what happens with people who just throw up all the time? They don't take the drug, right? They don't take it. So there's an example, extreme example, where you have the vomiting and such. We're not even going to get to the point we're going to see what's happened to satiety. On the other hand, there's plenty of cases, and particularly the longer people stay in the trials, of people who don't have any vomiting, but can have dramatic reductions in hunger and have that efficacy in weight reduction. So I don't know that it's the exact same pathway of those types of things, but the idea is to avoid the vomiting, because that's the big one, and enhance the decrease in hunger. Okay. So how do we do this? Well, as you know, there are companies that keep trying. Well, here's what we do. We're going to start at the top dose and just see what happens. Okay, that has been almost uniformly a bad plan, because with these agents, you really do have to do dose escalation. And if you're listening closely, you notice I'm using my words precisely. Shouldn't make that big of a deal, but it does to me. I am not using the word titration. Titration is, back in the day, we don't even do this anymore. Back in the day where you would say, we're going to titrate a drug, just like you would titrate like when you were in chemistry. Okay. You would titrate to achieve a certain result, right? So you would titrate because you would say, I want to get the LDL cholesterol to a certain degree, or you would titrate to get the blood glucose at a certain level. You would engage in titration. We're not doing titration with these agents, these newer agents. We're putting them in a fixed dose escalation. We're not saying we have to achieve this body weight as our goal. No, what we're doing is our goal is to get people to the top dose. That's our goal. We may not always get there. We're not titrating to anything. So it's this dose escalation, and time again, we find we do have to have dose escalation. And when we don't do that, then you end up with phase 2 trials that look like the drug's completely not tolerated and such. But that's because if you only look at the arm with the top dose, it's going to look bad in the vast majority of cases. Okay. Other things we can do: give them folks a drug holiday, smaller, more frequent meals, limit the energy dense and fatty foods, limit spicy foods, prioritize fruits and vegetables, these types of things. Antiemetics. I would caution everyone with regard to the antiemetics. When they have to be used, they're great. But what we've seen is sometimes people get put on ondansetron. You know, they get put on that and then they get left on it, like indefinitely. People just keep filling it. Well, guess what? One of the side effects is dose-dependent QT interval prolongation and cardiac dysrhythmias. So we've seen reports of people that they just got it refilled and refilled and refilled, and then they get their side points or something, and they get some sort of horrible dysrhythmia, and because somebody thought it was a good idea just to keep writing the prescription. So I would caution against that. Metoclopramide. Who knows better than endocrinologists that for everybody, that's not a benign drug for everybody. I mean, when we use it if we have to and such, but that can have some pretty nasty side effects. You have to be careful about. And there's other things. I mean, ginger, I put bleeding. I mean, that's just kind of report. I mean, I think ginger's probably okay. So we do use ginger and those types, and mints. But then the big one, again, something I've been just harping on a long time: hydration. There's evidence, or publications anyway, suggesting that GLP-1 receptor agonists don't just diminish appetite, but also diminish thirst. So if you're talking about reduction in food intake, what's in food? A lot of it's water, particularly if you're eating fruits and vegetables. So you're decreasing that. If you do have nausea and vomiting, you're eating less. That's decreasing fluid intake. And now if you add on top of that diminished thirst, that's a problem. So we see this frequently in the clinical trials, is that the creatinine goes up and the BUN goes up. Very frequently. So I'm just always, my coordinators and I are just always emphasizing the patients just the real need for hydration in people treated with these agents. And so here you get the GLP-1 dehydration cycle, where you get the nausea and then you get dehydrated. If you get dehydrated, you get more nausea, and then you get more dehydration. And that's when you end up with the, this was years ago, but we had a patient that, which was reported, in case anybody's curious, but we had a patient that, the patient came in for the study visit, was asked if they were doing okay, said doing great. 3 or 4 days later, we heard they were in the emergency room with acute kidney injury. Well, what happened? Well, what happened is this person was so wanting to stay in the study that they didn't tell us the truth. They were having nausea and vomiting and such. And so they ended up in the emergency room with acute kidney injury. So again, hydration. Other things to look for. So we talked about nutritional deficiencies. We're doing a study right now where we're measuring all these micronutrients and such. Well, how else am I going to know if people have micronutrient deficiency unless we measure them? Like we don't do that in clinical practice, or I don't. But it is true that people do end up with these deficiencies. And they're the exact ones that you would typically find with bariatric surgery, oddly enough. So these nutritional deficiencies frequently undiagnosed because we don't measure a big battery of vitamin assessments, whatever. We get the loss of muscle mass. We talked about that. Deficiencies of protein, fiber, water, B1, B9, B12. We really do see that. And I'm not talking about just bariatric surgery. I'm talking about people on the GLP-1s, right? Vitamin D, yeah, it goes down as well. And then, the iron and calcium, magnesium, these types of things. So here's a paper. This is our journal. I'm editor of this journal, the Obesity Pillars. Dr. Mozaffarian published, the things that you can do in order to address healthful nutrition in patients treated with GLP-1 receptor agonists. But overall, the idea is that you really want to maintain a healthful, balanced diet. You want to make sure you get adequate protein intake. That does seem to help. That does seem to help. And distribute the protein intake evenly across meals. Choose the whole grains and over refined grains. Optimize fatty acid ratios. Limit sodium intake. But the main thing is that when you have a patient that gets treated with a GLP-1 receptor agonist, the priority of nutritional intervention is no longer weight reduction. Okay, make sure I get that through. Okay, it's no longer, well, I'm going to take this and 500 calorie deficit. These drugs are pretty effective most of the time in achieving that. That's not the goal. When you have a person's being treated with a GLP-1 receptor agonist, and particularly the unimolecular but dual or triple agonist or whatever, the goal now is healthful nutrition with adequate hydration, and not so much we're going to start educating you on calorie reduction. That's not the focus. The focus is the healthfulness of the diet and adequate hydration, and that's a big change. That's a big change. And then the big thing is that'll be happening next year. It's already happening now. There are going to be big changes in how these drugs, the access to these drugs. There's going to be some limited coverage starting in 2026, $50 copay to get many of these drugs, because some of the major pharmaceutical companies have teamed up with the government, and they're going to offer this to Medicare patients. Medicaid, they're going to be using the most favored nation pricing to lower the cost of manufacturing costs, and they call it the generous model is what they call it. But if states start adapting this, then you're going to start seeing Medicaid patients having better access to these drugs, and then even direct to patient. It's not going to be a $50 copay, but maybe it's $250 or $350. Okay, and that will be on Trump RX. You probably heard that, Trump RX, and then on that also will have access to Lilly Direct or NovoCare or whatever. There's going to be other portals out there, presumably too, that are all going to go through this universal portal. So this really could broaden availability and access to many of our patients, where cost in the past has been such an issue. So this is the CME code for those that are looking into that. And anybody has any questions? We've got a couple of minutes. Yes. Yeah.
So pancreatitis, how we eliminated no, and now slowly we are 10 years ago, if they were triglyceride or gallstone related. So how comfortable if the CT criteria is negative, like this is fine, they don't have exocrine, it looks normal, but they had 2, 3 years ago an episode. How do you sort of go with that?
All right, so the question has to do with, what's this whole issue with pancreatitis and GLP-1 receptor agonists? What's the story there? So let's say you had a patient that had a history of pancreatitis. Okay, they had a history of pancreatitis, and now you're trying to decide whether or not that they're eligible to be on GLP-1 receptor agonists. Well, it's not as like you can go to the prescribing information and get that, okay, because it's not going to tell you that. What I think you can do is you can say, okay, why did they have the pancreatitis? Now, if you can say, well, they clearly had gallstones at the time, and they clearly had gallstone pancreatitis, and so there you go, gallstones are gone, gallbladder's gone. So I've made the judgment as a clinician that I feel it's in the best interest of the patient. I think that's perfectly legitimate. But wonder if you don't know why they had the pancreatitis. I think that's a sketchy situation then, and I think you have to be really careful. One of the things that's happened a lot, I think it's just because we're doing so many trials. It's remarkable how many, because we do get CTs and MRIs and everything. How once we're getting these things, we find these patients who didn't know it have at least imaging evidence of chronic pancreatitis. Where did that come from? Okay, and so maybe they had a history at some point in their life where they had increase in alcohol intake. But I mean, you would never know it. Amylase is normal, lipase is normal, liver is normal. They're not telling you they're doing any of these things. And the one, actually, I'm kind of glad you brought up this question because sometimes you get a neat case, So we had a patient. Suddenly, the amylase and lipase go up. Of course, it's blinded, so I don't know what they're on. Okay, but it goes up. Oh my goodness. Okay, well, we're going to follow the protocol, do these types of things. Again, all these are reported. And we stopped the GLP-1 receptor agonists, but the amylase and lipase didn't go down. And we're like, what's going on? So I said, well, is it possible that maybe some other drug? Well, there are other drugs out there that can cause the pancreatitis, right? So, I mean, you're going to look at triglycerides and these types of things. Well, it turns out patients with valproic acid, which is one of the most common medications that cause pancreatitis. And you see, yeah. And so then the question becomes, well, why would that happen now? And this is where it gets really good, pharmacodynamic-wise. Turns out the dosing of valproic acid is weight-based, right? It's weight-based. For a lot of the neurologists out there, it's based upon body weight, right? This person had lost over 100 pounds. Is it possible that this person now is receiving essentially higher drug exposure because of the weight reduction they had by being on the GLP-1 receptor agonist? So in a way, you're saying, well, is it due to the GLP-1 receptor agonist? Yes, but not because of a side effect of the drug. It's because of the intended effect of the drug, right? So I think you have to be a detective, and you really have to, you'll look into these things. But to answer your question is, I think if they had a definitive cause of the pancreatitis, and that's not there anymore, I think you can craft a pretty compelling note. But if they had pancreatitis and you don't know why, I think you're on a little bit more dicey ground with that. Yeah.
Was about the amylin.
Yeah.
Cargi. So
Yeah,
there
Cargi.
was amylin-type.
Yeah. Yeah.
Which we hardly ever use.
That's right.
Especially here in the
That's right.
lab. So why is it that now suddenly it's just so exciting and never ever like that?
Well, because we're doing it for two different purposes. Then it was, how do we stabilize blood sugars?
Was it type 1 too?
Yeah, it was type 1, how we stabilize, whatever. Now what we're doing is using much different doses and a much different scheme, and we're using dose escalation, and we're using all these types of things. And now we have evidence based upon what I just presented, okay? We now have evidence that there is a remarkable degree of weight reduction, okay? Now, when I did the podium presentation there at I think it was the ADA. I did the presentation there. Yeah, I didn't want to get too bubbly about it because you're at a national conference and everything. But in fairness, I mean, when you're getting 10 to 20% weight reduction with something other than the GLP-1, I mean, I think it's okay to celebrate wins, right? I think that's okay. And then if you look at certain arms of certain dose escalation schemes, the tolerability was remarkable. So what I would say is, I think it's okay to be happy, joyful about drugs that seem like they might be good for patients. I think that's okay. But I would temper that by saying this is a phase 2 trial. Let's see what happens in phase 3. Okay. But if we could have yet another way of having and another mechanism by which we can improve the lives of our patients, I mean, look at all these ones you saw I'm presenting. It's just remarkable, the variance of mechanisms such that we're doing. You said it right from the beginning. There was a time we didn't have anything going on, right? I mean, there was phentermine, right? I mean, there for a while we had the lorcaserin. I did a bunch of work on that, but that's off the market now. There is the topiramate, so and that's can be quite effective for some patients, and generally well tolerated. I mean, you do have the issues with the topiramate in some patients and whatever, and there's always the pregnancy issue requiring routine pregnancy testing, whatever. But efficacious with regard to weight reduction, efficacious with regard to a lowering of glucose levels and such. So that's pretty good. The naltrexone bupropion can be effective. The only issue I have there is there's so many drug interactions with the naltrexone bupropion. That's so I would almost reserve that for people that limited number of concomitant medications. And then there is more and more emerging evidence. I mean, in the past, I used to think it was just mainly theory, but there's more evidence to support it that people who eat based upon reward, or whatever's analogous to addiction or whatever, because it's got the naltrexone component to it. These people do see there is some evidence now beginning to support that those people may do a bit better than other people. Yeah, I mean, I can tell you the drug company's never going to do those studies. Okay, that's for sure.
Because there are so many people on these meds, like the non-ischemic anti-inflammatories, non-inflammatories.
Yeah. Yeah.
So what is because the report that they had in the journal from the hospital was quite high. I mean, I've seen a couple of patients have it. Is that some, because these are things that are not clearly explained as to why that happened.
Exactly.
And there's this new one that was published recently about cough, the chronic cough as a side effect of tirzepatide.
Yeah, I think if you look long enough and you do post hoc analysis, you're going to find it's remarkable how many things you can find, right? Particularly with meta-analyses and such. So I mean, I know people consider meta-analyses the gold standard, but I got to tell you, it depends on how you set up your meta-analyses and everything. I don't think anything is better than your straight up randomized, blinded, controlled clinical trial. And I think that's, and then you have to look at multiple ones, because even with large numbers, there's always going to be some aberrant finding. I always tell people, if you ever look at a study and they're in some finding that came out of nowhere, well, then it's not a real trial, because every trial is going to have something that didn't. Yes. Yes,
Don't know about it is more than what we know about.
exactly. That's
why
right.
I'll give you a bit cautious because it's a lifelong.
Well, what I can tell you is there's a study that you all may be involved in, we're involved in called FOCUS. And that is a long-term study looking at eye findings. Yeah. So let's, okay.
Dr. Susie, you talk about multi-drug problems and things like that. Here you're giving people 3 or 5. You'll be giving them 3 or 4 or 5 drugs in one pill.
Well, what you're doing is if it's a unimolecular, you're giving them one treatment, it just happens to have multiple effects. Okay. And I think that is a bit different than were there any questions? No. Okay. I think that is a bit different than taking one drug and then layering it on top of a. Yeah.
And the oral agent.
Yeah. The oral agents are coming, coming down the pike too. So there's so many.
There must be a really lot of money now being spent by the drug company for this because, a lot of them aren't going to work. So they must be looking at several things all at the same time. Because otherwise, they got to get one big one.
No, it doesn't need long insulin. Because their energy is focused on this. So there's less interest in insulin now and more interest. This is great. We needed all these options. There's no side effect.
Have any more insights into the non-responders? We have all those patients who are on max for the diet and seemingly does nothing for a few of these patients.
Yeah. Okay. So the question is, what about non-responders and such? I think you have to be cautious about, looking at non-responders and what it actually means. Give an example. I actually published this. There was a thinking that the proprotein convertase subtilis Kexin 9 inhibitors, okay, that there are a group of people out there that were non-responders. People say, how's this possible? Well, me and a guy, I know we were somewhere overseas in a meeting, whatever, but we know what was going on. Turns out, many times when we were doing our lipid trials, in order to be eligible to be in the study, you had to be a maximum dose of statin, right? So what would happen is an investigator that would say things that you shouldn't say would say, look, this PCSK9 drug is the best drug ever. It's going to knock the socks off your cholesterol. It's going to be amazing. And so a person went into the trial and they're like, well, if it's that amazing, why do I have to keep taking my statin? So they would stop the statin as they started the PCSK9 inhibitor. So if you look at what we call waterfall plot, right? You look at waterfall plot is where you look at all the patients, you see what their relative effectiveness is. And what was found is there's some people their actual cholesterol went up a little bit while on a PCSK9 inhibitor. And then with the majority of them, plummeting. Well, we went back and looked at those folks. And as it turns out, there were a lot of these folks, even if they were in clinical trials, that had no detectable drug that was being administered. And then number two, these are people who it looked like they had stopped their statin. So if the atorvastatin 80 was reducing the LDL cholesterol by 50, and they're on a PCSK9 inhibitor, wait a minute, yeah, and it also reduced by 50, but you stop the statin, then you end up with a net zero. You see what I'm saying? So we have to be very careful when we start talking about non-responders. You start looking at waterfall plots in isolation. What I've always said is if you're going to look at waterfall plots, you just have to look at them. Always look at them in contrast and in comparison to the placebo group. That's the only rational way that you can do this, okay? Because I think if you just look at the treatment arm, then all those things that can happen within the context of a clinical trial, you're missing those things because you're ignoring, free living people, and that which would be reflected, in the placebo group. So to answer your question is, do you know they got the drug? I'm telling you, within the context of a clinical trial where they were administered by the study staff, there are patients there was no detectable drug. Okay, I had a patient one time came in with her mom, said my atorvastatin is not working. I said, really? 80 milligrams of atorvastatin not working? Are you taking it every day? I swear I'm taking it every day. Just, they were offended that I do what even says. I said, okay, where's your pharmacy? Tell me the pharmacy. I called up the pharmacy. I called up the pharmacy. I said, it's been 6 months you filled a prescription. Okay. 6 months since you filled a prescription. She goes, well, you think you got me? I get my medicine from my doctor in samples. Really? I said, what samples they give you? He said 10 milligrams. So you're telling me your doctor gives you 8 10 milligram tablets for 30 days, right? 240 tablets every time, once a month. Is that what you're telling me? Okay, well, maybe I missed a few doses. Okay, so the point is, we're not trying to be accusatory to patients or everything, but what I'm suggesting is many times this so-called non-responders, there may be much simpler explanations other than in the case before we published the paper that examined all this. My buddies were all, well, it's genetic polymorphisms and people with specific this and specific that. But then after we published this, they went back and looked at their patients who they thought had some sort of genetic resistance. Turns out it was what we found, is there are much simpler reasons. So I think before assuming somebody is a non-responder, you have to be a big time detective and really be aggressive about finding out what's really going on. I mean, I even hear tell, I'm not saying my patients have ever done this. I've just heard, well, they will get a prescription for themselves and the drug ends up going to a family member or a friend, okay, because they had insurance coverage and the other person didn't, okay. A lot of potential reasons for non-responders that may have nothing to do with the ineffectiveness of the drug. Not saying it doesn't happen, because everything's on a bell-shaped curve, right? Not everybody's going to respond the same. They're hyper responders. Like, how do you explain that? Right? So yes, they're going to be hypo and hyper responders, but when you say non-responders, I would just be very cautious about that. Okay. All right. Thank you. Thank you.